Hi everybody, Miss Nikki here. We are going to finish chapter 17. So this is chapter 17 part 2, and we're going to cover hemostasis. So hemo is blood and stasis means to stop. So here's the official definition: a fast series of reactions for the stoppage of bleeding by clotting. We're going to see 3 steps, and I have them numbered. So this is the first step. But just remember that these clotting factors have to be activated. Right? So clotting factors and substances released by the platelets and the injured tissues is going to stimulate this process. So the first one here is vascular spasm. So initially you can see here there's a damage, there's a tear in a blood vessel, and this could be internal. I know a lot of times when we talk about hemorrhaging or we talk about tears in blood vessels, we're usually thinking external, but remember this is probably happening every day in various locations with your body. So don't think only extreme injury. This is really an everyday process, just on the micro level, right? Okay, so you see that there's a tear here in the blood vessel, and the first thing that's going to happen is vasoconstriction. So you see all the little arrows pointing in. The blood vessels are going to constrict and become smaller. There are chemicals that are released by the endothelial cells and the platelets that start to stick. So remember, platelets don't stick until the endothelial cells are damaged or until they stop producing that prostacyclin that we talked about in the last lecture. So basically, if you have a tear, it's going to expose some collagen. We'll see in just a second. It's going to expose collagen, the platelets, and they have one there. It's going to start sticking. And then there's going to be chemicals released that kind of initiate and start this hemostasis process. But step 1, vascular spasm, which is vasoconstriction of the damaged blood vessel. So step 2 here is your platelet plug formation. So platelets are going to stick to exposed collagen fibers. So remember this internal lining, I'll try to do them different colors. The internal lining is endothelial, and I said that's the same thing as epithelial, right? It's simple squamous epithelium. Then the next thing that you're going to have directly underneath, you're going to have connective tissue. Remember how connective tissue is vascular and it's always found underneath epithelial to supply blood because epithelial is avascular. And then eventually you're going to have smooth muscle. And that smooth muscle is what just caused the vasoconstriction. Okay, so you're going to have a release of chemicals which are going to cause more platelets to stick. So basically when that first platelet finds its way to the tear, it's going to stick and it's going to release chemical messengers and that are going to cause other platelets to aggregate. So basically it's come to the party, we need more platelets, we need to plug this gap. So that's why they call it platelet plug formation. This is an example of positive feedback. Go all the way back to chapter 1 in anatomy 1, and we talked about positive feedback, the recruitment or driving forward and all in one direction until the task is complete. So kind of like childbirth, platelet plug formation is one of those as well. Now here's where it gets a little tricky. Here is step 3, which is coagulation, but guess what? It's a multi-step process. So underneath you're going to have 1, 2, 3, and then you're going to talk about the processes that have to happen for coagulation to happen. So multi-step process involving many clotting factors. There's a set of reactions in which the blood is going to turn from a liquid to a gel. Remember we said blood is that weird connective tissue. It's liquid most of the time, but if you activate the fibers, we can turn it more into a jelly-like substance. So this coagulation is going to reinforce the platelet plug with something called fibrin threads. So here are your 3 phases of coagulation. So again, please make sure that you say 3 steps of hemostasis. And you list 1, vascular spasm, 2, platelet plug formation, 3, coagulation. And then underneath, tell me the 3 phases of coagulation. However you want to outline this. I just use the lowercase i's, right? So the first thing that's going to happen is prothrombin activator is going to be formed, and it's telling you what it's going to do, prothrombin activator. And what is prothrombin activator going to do? Prothrombin activator is going to turn prothrombin into thrombin. Then thrombin is going to catalyze fibrinogen to form a fibrin mesh, causes a cross-linking, and it stabilizes the clot. Okay, this is going to be phase 1, but remember we're still talking about coagulation. All right, so coagulation is step 3 of clotting or hemostasis, but we're talking about phase 1 of coagulation. So here's the intrinsic pathway. If the endothelium ruptures and you expose the underlying tissues, and that would be connective tissue with collagen being exposed, the platelets are going to cling and they're going to start the mobilization of these factors. So you can see this here is factor 12. This one's factor 11. This one's factor 9. All of these factors, blood clotting factors, are in your blood right now. They're floating around, but they're inactive. So what has to happen? You see the little A? They have to be activated. They only get activated if the endothelium ruptures and then now we're exposing some underlying tissue. What's the end goal? If I do the intrinsic pathway, I have this cascade effect of clotting factors, but my ultimate goal is to make this, which is prothrombin activator. On this side, extrinsic pathway, tissue cell trauma exposes blood to tissue factor. This should be inside cells. So what happens if it's all of a sudden in your blood? Oops, I forgot the D. What happens if it's in your blood? That is signaling tissue damage. So your clotting factors are going to do the same thing. They're going to go through a cascade and they're going to initiate prothrombin activator. But you can see that this pathway is a lot shorter. So this is the shorter, this is the longer. One's quick, one's slow. But both of them are going to result in prothrombin activator. The last thing that you should pay attention to is all of this calcium. So we've said time and time again that we need calcium for all kinds of things like nervous cell transmission and muscle cell action, but you also need calcium for clotting. It is kind of one of the cofactors that needs to be present for some of these clotting factors to be activated. So what happens once we get prothrombin activator? Once we get prothrombin activator, it's going to take prothrombin and turn it into thrombin. And then what does thrombin do? Thrombin is going to take fibrinogen and turn it into fibrin. Again, you've got calcium showing up again. Also, we have another activation of a clotting factor, right? And then eventually we're going to form this cross-linked fibrin mesh. And you can kind of see these little strings that are, these fibrin strings that are coming out of solution, and they're linking all the red blood cells and this area, there would be a blood vessel here. So kind of to sum it up, intrinsic, these are factors within your blood. It's triggered by negatively charged surfaces. It activates the platelets, uses factors that are present within the blood, slower clotting pathway. What about extrinsic? It's factors outside the blood. If the blood has exposure to tissue factor outside of the blood, this is an extrinsic factor. So remember, this is supposed to be inside cells. So if it's in the blood, there's something wrong. The extrinsic bypasses several of the steps, so it's faster. So again, you have two ways to initiate prothrombin activator. One's a fast way, one's a slow way. Again, I've summed it up. Intrinsic pathway, if a vessel ruptures, platelets cling to the collagen, you release something called PF3, and this is going to combine with other factors to form what? What's our whole goal? Prothrombin activator. If you're doing the extrinsic pathway, a cell is damaged, a protein factor called tissue factor is exposed on the cell surface and triggers prothrombin activator. Now we get to talk about clot retraction and repair. So we've formed a clot, so what? The clot must be stabilized and removed once the damage has been repaired. Imagine if you left a clot build up inside all of your blood vessels. If I said these vascular tears are happening all the time, you'd have a lot of clots remaining. So you're going to do the step number 1, which is the vascular spasm. Then you're going to do the platelet plug formation. Then you're going to do coagulation and do the 3 phases of coagulation, and you're going to end up with a clot. I forgot the L. There we go, clot. And then you have to remove the clot once the damage has been repaired. So actin and myosin are in the platelets, and they start to contract within about an hour. Platelets are going to pull on the fibrin strands that you've created, and they're going to squeeze the serum. So the serum is the plasma minus the clotting proteins from the clot. If you've ever had a scab on the knee like we were talking about, it kind of oozes a little bit. So as that clot is happening, you're actually pulling. I try to think of it kind of like a shoe. So if you're tying your shoe, you know how your laces are threaded in between. So when you pull on those laces, the shoe gets tighter. It's kind of the same process, but it's the fibrin threads that are being pulled on to tighten or bring the 2 sides of the blood vessel tear closer together so we can repair it. Remember we talked about platelets have something called platelet-derived growth factor? We mentioned it just briefly last lecture. It's going to stimulate the division of the smooth muscle and rebuild the blood vessel wall. So the platelets have this PDGF, or platelet-derived growth factor. There's also something called vascular endothelial growth factor. So this would stimulate the endothelial cells inside the blood vessel to multiply and restore. So the repair is complete. What do we have to do? We have to go back and remove the clot. So basically the clot is just a temporary way to keep the damaged blood vessel together so that we can kind of stitch it back and replace all of the damaged tissue. So inside the clot, along with the clot, we have this plasminogen. Plasminogen is going to be converted to plasmin by tissue plasminogen activator, factor 12, and thrombin. So again, it's another process that requires several players. So plasminogen is in the clot. Plasminogen is going to get converted to plasmin. What converts it? Tissue plasminogen activator. So tissue plasminogen activator is what's responsible for turning plasminogen in the clot and converting it into plasmin. Plasmin is going to digest the fibers. So plasmin is going to go to the fibrin, and it's going to start digesting and removing the clot. So there are some limiting factors. You can have some factors that are going to decrease clot growth, and you have some factors that are going to increase clot formation. So here, swift removal and dilution of clotting factors is directly related to your blood flow. So you know how if you're on a plane and they tell you if you're on a super long flight, you need to do exercises. You don't want to stay in that seated position. You want to get up and walk around. If you're having blood flow issues, blood pressure issues, you could have some of this thrombin be activated and start the clotting process even though you don't have a tear. So you would just have a clot forming even though you don't need one. And you can imagine that clot could travel in your bloodstream, and it could cause problems if it got lodged in your brain or in your lungs or in some of the small vessels within your leg. Also, what stops the clot from forming, what stops this thrombin from just automatically being activated, we have this enzyme. That's all I'm really going to tell you. It's a protease. And this enzyme is naturally occurring in our blood, and it stops thrombin from just randomly initiating the clotting process. And then the prostacyclines, remember these are in the endothelial. These are the ones that stop the platelets from sticking to begin with. So two types of disorders that we'll just mention. One is thromboembolytic conditions, where you have undesirable clot formation. So in this case, there's no damage. You have no endothelial damage, no cellular damage, but thrombin is still turning into fibrin. You still have that fibrin mesh, you're still clotting, but there's no damage. Then you have bleeding disorders. Most of us think of hemophilia. This is some sort of abnormal clot formation. So what if you're missing a clotting factor? So one of those clotting factors that's in the intrinsic cascade, if you're missing that clotting factor, then you're not going to make as much prothrombin activator. It's going to take longer for you to stop bleeding. This last one, disseminated intravascular coagulation, this is widespread clotting and severe bleeding due to the fact that all your factors are in use. So remember, those clotting factors are in your blood, but we only make so many. So what happens if you have widespread clotting happening? You have septicemia, you have some sort of systemic body infection, and all of your clotting factors are in use. Then it's finite, you only have so many. Then blood transfusions can initiate this as well, and pregnancy complications. Just to talk about these thromboembolytic conditions just a little bit more, what happens if you have a clot in an unbroken blood vessel? So we said there's no damage, right? You have a clot that is persistent, it's not being broken down, it was initiated not because of damage, just because of circulation issues or some other clotting process issue. So we call this a thrombus. So a clot that develops and persists in an unbroken blood vessel. It may block circulation and it can lead to tissue death. Coronary here, coronary thrombosis, we're talking about heart vessel. So what if one of your heart vessels that feeds your cardiac muscle, which pumps your heart, what if that all of a sudden has an occlusion or a clot in it, and now you can't pump as much blood to your heart muscle? It's going to cause a problem, right? Maybe a heart attack. An embolus, most people use the term embolism when they're referring to it, but an embolus is when you have a thrombus that's free floating. So the thrombus breaks off and is free floating in the bloodstream. The problem is we have some really small blood vessels, and that this clot could get stuck and it could cause tissue death in particular areas, especially where you have small blood vessels. So pulmonary, this is the lungs, and then cerebral is the brain. So imagine if you have a clot that's plugging a small blood vessel in the brain, you can have neuron tissue death in the brain. You cannot replace that, right? The lungs, you can have a pulmonary embolism, the clot breaks off into and is free floating and happens to get lodged in one of the small blood vessels of the lungs, and it can cause problems with getting enough oxygen and with breathing. So no laughing matter if you cannot break down a clot. If they continue to develop and persist, you're going to have problems. Remember, real quick, sorry, TPA, tissue plasminogen activator. What did TPA do? TPA broke down the fibrin, right? The fibrin mesh. So TPA is something that we can give patients who have these persistent clots. We can give them tissue plasminogen activator, and hopefully it'll break down the clots. So there is treatment, but you just have to know that you have them. So what are some of the risk factors for these unwanted, I'll just remind you, what is a thromboembolytic condition? Unwanted clotting. So if you have unwanted clotting, a risk factor could be atherosclerosis. So this is a rough patch. It's usually fats or cholesterol. It's a plaque buildup, right? And the platelets will start to stick. So basically you're starting or initiating step 2, the platelet plug formation, even though you do not have any damage to the blood vessel. Also, slow blood flow. So clotting factors can accumulate and they will initiate the clotting process because they're accumulating in a certain area. And that sometimes we refer to that as deep vein thrombosis. How do you prevent this unwanted clotting if you do have it. We did talk about TPA. You could give the drug, and some people call it the clot buster. But there are some other simpler ways. This is kind of expensive, and we wait till you actually have a clot. But aspirin, so antiprostaglandins, this has something to do with stopping the platelet plug formation or slowing it down. So if you have aspirin in your bloodstream, it won't allow platelets to stick together as effectively. Heparin. Heparin is an anticoagulant, and it's going to work kind of the same, on the same action as warfarin, which is Coumadin. You might know it as Coumadin. So both of these are going to stop or reduce clotting factor creation. So this happens in the liver. So both of these are basically going to have you make less clotting factors, and if you have less clotting factors, then you're not going to be able to initiate as much clotting, or this unwanted clotting is not going to be able to happen as well because you have reduced clotting factors. You can also take specific drugs which will inhibit thrombin. So even though you have thrombin in your bloodstream, it'll kind of bind to the thrombin and inhibit it from turning into the fibrin. So bleeding disorders here, just to list a few of them, the thrombocytopenia, right? So it's telling you penia, that means low. Cytocell, we're talking about thrombocytes, low platelets, right? So you should be able to start getting used to looking at the word and figuring out what it means. What if you have some sort of bone marrow suppression? So something has happened and maybe it's just targeting your megakaryocytes. All of a sudden your megakaryocytes aren't generating enough platelets. That's going to cause thrombocytopenia. What about impaired liver function? So remember we said those clotting factors. Those clotting factors need the liver in order to be created. So if you have any sort of liver disease, inflammation, so cirrhosis of the liver, damaged liver, hepatitis, just an infection, or if you have a vitamin K deficiency, that's going to affect your ability to make clotting factors. And then we mentioned hemophilia already. This is hereditary, it's genetic, and it will cause a deficiency in some of your clotting factors. So hemophilia can be very serious depending on which clotting factor is affected. We still have to talk about blood grouping, but I wanted you to kind of look at this slide and see that if we did some sort of diagnostic blood test like a CBC or complete blood count, you could look at that test and it would tell you a lot if you know anything about the blood. So I gave you some examples here. What about color? What if it's pale red? You know that's going to mean low oxygenated blood. Not necessarily a good thing or a bad thing, but it's going to tell you something. Hematocrit. What happens if you have low hematocrit? That means you're going to have low oxygen carrying ability, right? You have decreased red blood cells for some reason in your total volume. What happens if you were to put the red blood cells on a slide and all of a sudden you see that they're sickle shaped? Well, you know that that's going to be decreased oxygen availability. You know it's going to have something to do with getting lodged in organs, causing pain. You know that there's an issue. What about white blood cell count? What if you had a super high eosinophil count? What would that tell you? So remember we had neutrophils, which were bacteria. We had basophils, which were had something to do with histamine, and we had eosinophil, that was parasitic worms, right? That would tell you something. Also, high eosinophil count, remember we said it has something to do with asthma. Prothrombin, they can do a time test. How long does it take for prothrombin to be activated in your clotting process? So I'm sure it would be different if it was 1 minute versus, let's say it took 10 minutes for bleeding to stop for you. That's going to be a problem. Maybe there's some sort of hemophilia. Maybe there's a vitamin K deficiency. Maybe there's something wrong with your clotting factor cascade. So in your textbook, I'd have to double check it's the same page, but in the back of your textbook, it walks you through a CBC and tells you what the chemistry of blood profile should be, what's normal, what's below, above. So it's kind of interesting if you care. So some of the developmental aspects of blood. So fetal blood cells are going to form in the yolk sac, the liver, and the spleen. We'll talk more about this when we get to reproduction. Red bone marrow is active by the 7th month. Blood cells are going to develop from mesenchymal cells. A fetus has different hemoglobin. So fetal hemoglobin F has a higher binding affinity for oxygen than the hemoglobin that we produce after birth. And then, of course, as you get older, there are some blood diseases that become kind of common. So chronic leukemias, where you have abnormal white blood cell production, anemias, where you're not making enough red blood cells, and then some clotting disorders. Some of those clotting factors aren't working as well. Your liver's not making as many clotting factors. Usually these are precipitated or exaggerated by disorders of heart disease and blood vessels, or the declining immune system that happens as we get older as well. This last section, we're going to talk about blood grouping. So most of us know I'm type A, I'm type B, or I'm O, or I'm AB, but we're going to get into a little bit more detail about how we do the blood typing and what it means, and we'll talk about some of the genetics of it as well. So transfusions, if we needed to give you a whole blood transfusion, it's because you have substantial blood loss. Anything over 30% can be fatal. We could also give you packed red cells. So we're talking about red blood cells. So if I needed to increase your oxygen carrying capacity, I could give you just the packed red blood cells, so the plasma was removed. Also, I could give you just plasma if I needed you to have water and electrolytes and antibodies. So sometimes we separate them out and give you which portion you actually need. So why do we have to do this blood typing? Well, because if you give someone the wrong blood, it's incompatible and it can be fatal. Most of us know this by now. You get blood typed, you have to receive your blood, or you have to receive the universal donor, but we didn't know this until 1901. So in 1901 is when the first medical researcher realized that we have different blood groups. Before, we would just give people transfusions, and sometimes they would die and sometimes they wouldn't. It was a little bit better statistically because people in the same neighborhoods, right, the same hospital, they were probably somewhat related. So we did see, several people had the same blood type. But I just want you guys to realize we haven't known this forever. So red blood cells have glycoproteins. So they have a sugar protein tag. We call that tag an antigen, something on the surface of the cell. It's unique to each individual, and it's perceived as foreign if the transfused blood is a mismatch, and we call that agglutination. So clumping is not the same thing as clotting. So let me just write this. Clump, not clotting. So they're two different things, right? Clotting is that very complex pathway that we use to basically plug up and repair a blood vessel or blood vessel break. This clumping, we're going to call it agglutination, and this happens only when you're given a mismatch or the wrong transfused blood. So an antigen is either present or absent on the outside of a red blood cell, and that's how we classify the different groups. There's also something called an Rh factor, and this leads to if somebody says their blood is positive or negative. So here are the 4 blood type groups, AB, AB, and O. They can all either be positive or negative with that Rh factor. Based on the presence or absence of 2 agglutinogens, A and B, on the surface. So if you're type A, you only have A agglutinogen. If you're B, you only have B. If you're AB, you have both A and B. And if you're O, you have neither. So I usually think of O as naked. Blood may contain anti-A or anti-B antibodies, agglutinins, that act against transferred blood. So let's look at the table, and it'll probably help make this make a little bit more sense. How's that? Okay, so here's the blood group, AB, B, A, and O. And they're saying, what are the antigens? What is on the red blood cell? So the red blood cell is going to have antigen A and antigen B. Do you see how the A is kind of a purple spike and the B is a round circle, green circle? So if you have blood type A on the surface of your red blood cell, you're expressing both A and B proteins. If you're blood type B, you're only expressing B's on your red blood cell. If you're A, you're only expressing A's on your red blood cell. What about O? None. You're naked. So then the other part that they talked about was, what are the antibodies that you make against other blood types? So those are called agglutinins. So agglutinins are the antibodies. So if you're blood type B, you make anti-A's. If you're blood type A, you make anti-B's. If you're O, you make anti-A's and B's, and if you're AB, you make none. So I know these words are confusing, but agglutinogens, antigens, they both end in gens, right? Agglutinins, antibodies. And then they tell you what's the blood you can receive and what's the frequency in the population based on race. So a lot of people are usually surprised that overall, you can see it's different for different races, but you can see overall that O is the most popular, so most common. This is a good thing. Followed by A, followed by B, followed by AB. And you can see it pretty much extends across all races, that this is kind of first, second, third, fourth. We also have an RH group. This RH group, basically your red blood cell is going to have a RH tag, as well as, let's say this is A blood, as well as an A tag. So this RH agglutinogen, remember that's an antigen tag on the red blood cell. If you have RH positive, it indicates that one of these factors is on your red blood cell. So we usually say someone is A positive or they're A negative. So positive indicates presence. So if you're positive, you have the RH factor. If you're negative, you are naked, right? You have no RH factor. So anti-RH bodies are not spontaneously made, only if they're exposed. So if you have an RH negative individual that receives RH positive blood, now you're going to make antibodies against it. Why? Your body sees this as foreign. You're supposed to be this. This is your cell. And all of a sudden I have a bunch of these floating around in my bloodstream. Your immune system says you're not supposed to be there, and it kills or attacks. And if I'm giving you blood, there's probably a reason I'm giving you blood, and I don't want your red blood cells attacked. Second exposure to RH positive blood will result in the typical transfusion reaction. So usually it's okay the first time if you received a little bit, but if you receive it again the second time, you've now made tons of antibodies against it, and they're ready to pounce and attack that blood that you're being given. So some of you might be familiar with this hemolytic disease of a newborn, or erythroblastosis fetalis. So basically what happens is mom is RH negative. The fetus is RH positive. Your immune system doesn't know that you're pregnant. All your immune system sees is the RH positive blood cell. So if mom is negative and baby is positive, the first pregnancy, not as terrible. Mom is exposed to the RH positive blood. First baby, no problem. But now mom has made tons of anti-RH antibodies. So guess what? When she becomes pregnant the second time, when the baby's still developing, all of a sudden her immune system is attacking the RH positive baby. So we can treat this with pre-birth transfusions. We also can give RhoGAM serum, which is going to kind of decrease the immune response to generating those anti-RH antibodies. So I wanted to go over this with you kind of on a blank slide real quick. So let's say I'm blood type A. If I'm blood type A, here's my red blood cell. And what do I have sticking off of my red blood cell? I'm going to draw little triangles because the other one had triangles, right? So if I'm blood type A, I am making antigens for A. And then we said you also have antibodies for B. So over here, you have antibodies floating. Again, I'm no artist, right? You have antibodies for B, so we call them anti-Bs. So the problem is, if you're blood type A, and I come in and give you blood type B, what's B? Got my red blood cell, and I'm going to have antigens for B, right? So I've got antigens for B. So what if we mix these two together? What happens to all of these antibodies? Antibodies will bind. These anti-Bs will come here, and they'll bind. Guess what? You don't give somebody just one red blood cell, right? So here's another. If we give you red blood cell transfusion, we're giving you millions of red blood cells, right? So here's another B. And what's going to happen is the antibodies are going to bind it, and then everything is going to stick together or clump. So if you have low blood, and I give you the wrong blood type, and we have this clumping happening, agglutination, this defeats the whole purpose, right? Those red blood cells can't bind oxygen, move through the body. They start all clumping together, and we've defeated the purpose of giving you blood type. Also, those clumped cells can end up in places we wouldn't want them, right? We said cerebral, pulmonary, coronary. So this is why you can't give the wrong blood to a patient. It's going to cause this agglutination or clumping, and then that can cause problems within the blood vessels and cause issues in different organs of the body. So transfusion reaction, this agglutination occurs only if mismatched blood is transfused. So like the last slide, if you take A blood and B blood and mix it, you're going to have agglutination occurring, or the clumping of blood. So why is this bad? Obviously, if you have clumping, you're going to reduce the oxygen carrying capacity because your red blood cells are all clumped together that we just tried to give you. You could decrease blood flow because now you have this clumped agglutination mess blocking a blood vessel. And then also hemoglobin is the red blood cell can rupture, and the hemoglobin can be dumped into your bloodstream, and then the hemoglobin can get stuck in your kidney tubules and cause renal failure. Some of the symptoms: fever, chills. This has to do with low oxygen. Low blood pressure, increased thickness of blood, right? Rapid heartbeat. Your heart's trying to push the blood faster because your blood pressure's low. Nausea, vomiting. Treatment. We can prevent kidney damage by flushing you with diuretics, wash out the hemoglobin. But one of the things we try to do is give somebody a universal donor, right? So if you're type, stop, it won't work. If you're type A, I can give you, if you're type A, I can give you A blood, or I can give you O blood, Remember, O blood is naked. So it will not, your body basically won't see it. It's not like your antibodies will see anything because the O's don't have any antigens on the outside of them. What if you're type B? If you're type B, I can give you B, or I can give you O. If you're blood type O, I can give you O. And if you're blood type AB, I can give you O, or A, or B, or AB. So that's why they call O the universal donor. I can give O blood to any of the blood types. AB is the universal recipient because AB can take all 4 blood types. So hopefully by now some of these A words will make a little bit more sense. So when serum containing anti-B or anti-A or anti-B agglutinins, what does that mean? Agglutinins means antibodies. When a serum containing anti-A or anti-B agglutinins is added to your blood, agglutination, what's agglutination? Clumping, will occur between the agglutinin antibody body and the agglutinogens. These are the antigens on the red blood cell. So go back and read that statement a few times and make sure that you know which A word means antibodies, which one means antigens, and that agglutination, you understand that that's when the clumping occurs because the antibody bound to the antigen on the wrong blood that was given to you. If agglutinogen is present, antigen is present, clumping of the red blood cells will occur. Positive reactions indicate agglutination, clumping. Blood is typed for ABO and for RH factor. So, how do we test blood group? This is a little hard for us to think about for some reason, but we look for agglutination or clumping. So we took the process that we don't want to happen in the body and we used it to make a test so that we could tell what blood type. So this is agglutination. Agglutination. We do not want this to happen in the body. Do not want in body. But guess what? We can design a test for it so that we know what blood type you are. So here's blood type AB. I put a drop of AB blood, I put a drop of AB blood, and then I'm going to put serum. I'm going to put anti-A and anti-B serum. If I'm anti-A serum, that means I have antibodies for A. So what does anti-B mean? I have antibodies for B. So if I put AB blood down, and then I put a drop of anti-A on top, we should see agglutination. Remember the red blood cells for AB, they have A tags, and they have B tags. Those tags are called antigens. So if I put this AB blood on each spot, and then I put anti-A, so what's going to happen? The anti-A is going to come and bind to the A antigen. What's going to happen to anti-B? It's going to come and bind to the B antigen, and we're going to see clumping or agglutination. So basically what the test is showing you is what you would not want to happen in the body, but we're using that to tell what blood type it is. So go to the next one. I have just A. I put a drop of A blood and a drop of A blood. I put down anti-A. I put down anti-B. So if I have A blood, is the anti-A going to bind? Yes. Am I going to have agglutination? Yes. Over here, if I put down anti-B, This is blood type A. What does blood type A have? All it has is A tags. So what if I add anti-Bs? Do antibodies for blood type B bind blood type A? No. So do I have any agglutination? No. Here's blood type B. Blood type B, I put a drop here, I put a drop here, I add anti-A, and then I add anti-B. If I have blood type B, does anti-A have anything to bind to? No. So you see no agglutination, no clumping. Antibodies for B, will they bind B? Yes. So I'm going to see agglutination or clumping. So then here's our O. Remember how I said O's are naked? So what if I add anti-A or anti-B? If I add antibodies for A, does it recognize blood type O? No, no clumping, no agglutination. If I add antibodies for B, do they recognize anything on blood type O? Nope, no clumping, no agglutination. So basically, when you do your blood group test, you put a drop of blood down, you add the anti-sera separately, and then you look for agglutination, and it'll tell you what blood type it is. So here are some unknown samples. I have sample 1, 2, and 3. So I put a drop of blood here and here. I put anti-A, I put anti-B, I see agglutination. Here's anti-R. I also put a drop of blood here. I added anti-RH serum. So when I look at this, I see agglutination for A, I see agglutination for B, and I see agglutination for RH. That means they're all present on this unknown sample. If the anti-A binds, that means A antigen has to be present on the red blood cell. If I see B binding or agglutination occurring or clumping occurring, if anti-B binds, it has to have a B antigen present on the red blood cell. If RH binds, the antibody for RH, that means there has to be that RH factor on the red blood cell as well. So this blood has to be AB positive. So now, second unknown, I put a drop of blood on all 3. I add anti-A, and I see that it's positive. That means A has to be present. What about anti-B? Nope. What about anti-RH? Nope. So this person has A negative blood. Third sample. I have drop of blood, drop of blood, drop of blood. I add anti-A, none. Anti-B, yes. Anti-RH, yes. So there's no A's present, there's B's present, and there's a positive factor. So this blood type has to be B positive. So even though death can occur from the shock, from the low blood volume, or for any of the other symptoms that we talked about, like renal failure, you can replace the volume of the blood. So if this were to happen accidentally, you could give saline. That would increase the blood volume and the blood pressure. You could flush the system, right, and get rid of those hemoglobins that are clogging up the kidneys and causing the renal failure. So you can replace the volume, but remember that's not going to replace the oxygen carrying capacity of the red blood cells. So the red blood cells are all clumped up together. They're not going to be able to carry oxygen. So we can try to flush those agglutinated antibodies and red blood cells. We can flush them out, but that doesn't mean you're going to have the oxygen carrying capacity because you have less red blood cells. So hopefully all that made sense. Email me if you have any questions. Bye.